Hi students, I'm Dr. Sidharth Sethi, and over the next few minutes, I'll be discussing with you the questions which came from pediatrics in this INICET exam. And before I talk about these questions which came, if we talk about the analysis of this exam, I think this exam was a very predictable exam. We just had to just stick to the basics, what we discuss in the classes, and I can tell you more than 80% of the questions which came in this exam were from our classes only, and we discuss all of these topics in our classes, and I'll be showing you some screenshots of our class as well. And remember, these were very important topics which we told you in your class that these are very important topics bound to be repeated. So I would just say to all of you that you need to revise your topics, revise your notes, and in your classes when we tell you please put a star here, this is a very important topic. It is important. You need to at least revise those very important topics. So over the next few minutes what I'll do is I'll be discussing these important questions with reference to standard textbooks, with reference to what we taught in your classes. The first question was a very simple question, and we have been seeing in the last many NEETPGs and INICET exams that question on milestone definitely comes. And whenever I discuss the neonatal reflexes in my class, we always tell you that handedness develops at 3 years of life. So there is no doubt about this. Handedness develops at 3 years of life, and early hand preference is always abnormal. So this is what we discuss in every neonatology class. The next question is a very controversial question, and maybe I would like all of you to maybe email me someday and tell me what was the actual question. What was the actual question? Because the question was how to measure height of a child. I think this question was an incomplete question. If you could tell me more about this, whether this child was having cerebral palsy or you have a critically ill child. Because there are many ways of looking at a height. And all of you have been taught about the arm span. Remember, your height is equal to your arm span at 10 to 12 years of life. Okay, your height is equal to your arm span at 10 to 12 years of life. So, you can have an approximation of your height from your arm span. However, if you have a patient who is sick, now you can do a height which is called a knee height. So as you can see, this patient is sitting here and your leg is completely perpendicular here, and you look at the knee height. Now, especially in patients who are sick, critically ill, patients who are cerebral palsy babies, who cannot stand, you may use knee height. So all of you, if there was a question, if they were asking about a cerebral palsy patient, a patient who is critically ill, you can put knee height here. Otherwise, most of the studies talk about arm span. So if they are not talking about cerebral palsy, a patient who cannot stand, a patient who is sick in the ICU, then knee height is the answer. Otherwise, arm span is the most close approximation to calculate the height in a child. Now, there was a question on an acute exacerbation of bronchial asthma. Multiple options can be correct here. X-ray, oxygen, prednisolone, salbutamol. So all of you, we've been discussing in your all classes of respiratory system how to manage an acute severe asthma exacerbation. We also discuss about how to categorize an acute severe asthma exacerbation. So of course, we do oxygen, we give nebulized salbutamol. If he's not improving, we go to ipratropium bromide, subcutaneous terbutaline, epinephrine, oral prednisolone. So this is the exact algorithm which I taught you in your classes, and this was taken from OPGI textbook and from the Nelson's textbook. So X-ray, as you can see, is not the standard protocol to do in all exacerbations of bronchial asthma. So X-ray is not a standard protocol. We'll go for B, C, D here. Start oxygen, give salbutamol inhalation, ipratropium bromide if required, and you can also give him oral prednisolone at this point of time. The next question was on cyanotic heart diseases with increased blood flow. And in all of your classes, we do talk about classification of congenital heart disorder. This is one of the clip from our class on eMedicoz where we talked about cyanotic heart disorders, classifying them into increased pulmonary blood flow and reduced pulmonary blood flow. So remember, truncus arteriosus is cyanosis with plethora. Total anomalous pulmonary venous connection is cyanosis with plethora. Now TGA, almost 50% of TGAs already have a VSD. So TGA will be an option because almost half of them already are associated with VSD. Now in hypoplastic left heart syndrome, like we discuss in all of your classes, since the left ventricle is not working, in the initial days of life, the ductus arteriosus is open. So right ventricle becomes dominant in these patients in the first few days of life, and these patients do have history of increased pulmonary blood flow because the right ventricle is dominant. All the blood from the ductus arteriosus is going to the right ventricle. So these children do have pulmonary edema. Okay, so the second option which was true is also hypoplastic left heart syndrome. And we discuss in all of your classes that tetralogy of Fallot has pulmonary stenosis. So there is oligemia. Epstein's anomaly, because of the downward displacement of the tricuspid valve, right ventricle is small, hypoplastic, oligemia. Tricuspid atresia, right ventricle is small, hypoplastic, oligemia. Now this was a standard question which we have been talking to you in each and every class of yours. So this is a slide which I show you in each and every class of yours, that tetralogy of Fallot is the most common cyanotic heart disease beyond infancy. And we also discuss how it looks like a boot. Because of the right ventricular hypertrophy, there is uplifting of the apex. So this is a typical coherence abort. So there was no doubt about this, that a cyanotic heart disease with boot-shaped heart is tetralogy of Fallot. Now there was a very nice question on what all do you need in IV cannulation of a newborn. And all of you, I have been telling you in each and every class of yours that AIIMS has a YouTube channel. And the name of the YouTube channel is AIIMS Preterm Baby Package. AIIMS Preterm Baby Package. So there are many videos in AIIMS Preterm Baby Package, and one of the video is also on IV cannula insertion. Let's just listen to the video for 10 seconds.
For establishing a venous access, we need sterile gloves, spirit and povidone iodine swabs, sterile 24 or 26 gauge cannula, 1 ml syringe, normal saline, tape and scissors, and Tegaderm. A splint is optional. Intravenous access can be established at the following sites: veins on the dorsum of the hand.
So let's go back to the question. And the question is, what all do you need for establishing the venous access in a newborn? And like the AIIMS preterm baby package video clearly says that ideally you need a 24 or 26 gauge needle for putting a cannula. So the answer should be actually B, normal saline adhesive tape. Ideally it should be a 1 ml syringe. So if you have an option of B, D, E, I'll go for B, D, E. But you have to check in your exam. So since most of the students told us that there were option of BCDE, so I'm going for BCDE. However, a 1 ml syringe would be a much better syringe to flush in a newborn and especially in a preterm child. Okay, so 24 or 26 gauge cannula, normal saline, adhesive tape. Do look at the AIIMS preterm baby package. If you are specially planning to join and go for INICET exam, you should watch those videos. Now the next question was again a very predictable question on congenital CMV infection. And in each of your lectures, I at least spend 1 hour on torch infections. So this is one of my class and where we told you that torch infections, CMV is very common. And look at stars. I told you to put 3 stars here. This is the most common non-syndromic sensory neural hearing loss in children. Remember, sensory neural hearing loss is common in symptomatic CMV. So those children who have symptoms, they have more deafness. Remember, 90% of CMV does not have any symptoms overall. But those children who have symptoms, 30 to 40% of them have deafness. And each and every class of yours, I discuss with you the July 21 INICET exam. Since last 1.5 years, we've been telling you this is a very important question. Remember that especially in India, all of us are exposed to CMV. So mothers in India, Africa, their IgG is positive. So they don't get primary infections, they get reactivation. So India, Africa more commonly have reactivations and they have low risk of transmitting CMV. So remember, CMV is the most common cause of non-syndromic deafness in children. We've been told, in each and every class of ours. In India, in developing countries, primary infection is rare. Reactivation is common. In America, primary infection is common. 90% of CMV is asymptomatic, and we go for ideally culture of the virus in the urine or saliva in the initial few weeks of life. Now, a favorite question of your examiners and a favorite topic of ours is cystic fibrosis. In each and every class of yours, I spend at least an hour on recurrent pneumonia, and we do talk about cystic fibrosis in all of our classes, and we spend a lot of time on cystic fibrosis. So please go through your notes, and we've been telling you that if someone asks me, sir, what question will come in your next NEETPG? I always say you should know about 7Q. CFTR is on 7Q, Williams syndrome gene is on 7Q, and the most common mutation in cystic fibrosis is deletion of the phenylalanine at the 508 number position. So deletion of this codon TTT at the 508 number position. So of course the answer was a simple CFTR gene codes for a chloride channel, a cyclic AMP regulated chloride channel, and there is deletion of the phenylalanine at the 508 number position. Now the next question was on febrile seizures recurrence. And students, in each class, I tell you, if you are planning to go for INICET exam, remember your INICET exam examiners are from All India Institute, but they're also from JIPMER. So this is a very common question, and I put a star here in each class of mine, and I tell you, if you are going for JIPMER, you should know few tables of Nelson's textbook. And even if I don't remember all the options of this question, students, you should know all about this table, because in JIPMER very commonly they discuss questions on recurrence risk of febrile seizures, treatment of febrile seizures. So in the last many years, they've been asking about what are the recurrence risks of febrile seizures. If there are no risk factors, 12%, one risk factor, 25 to 50%, two risk factors, 50 to 59%. So remember the major criteria, and I can tell you in your INICET exam this year, they must have asked you these three options. Onset less than 1 year, duration of fever less than 24 hours, fever between 38 to 39 degrees Celsius. These are very important risk factors for recurrence of febrile seizures. So of course, onset less than 1 year, duration of fever less than 24 hours. Remember, fever between 38 to 39 degrees Celsius are major risk factors for recurrence of febrile seizures, which you should know, because you've been told about all of this in your class. So you should just revise those important notes. Now, one of the professor at All India Institute, one of his passion is urinary tract infections, and two questions came on urinary tract infections in your class. Now, the first was recurrent UTI. Remember, E. coli is the most common cause. Now, remember that nowadays in children, especially girls, we've been seeing that bladder and bowel dysfunction increases the risk of urinary tract infections. This is so common. Every day in my clinic, students, I see children who come to me, girls, a 6-year-old girl with severe constipation. She holds her urine, and she is not even, passing stools for many days. This increases the risk of UTI, especially if they have underlying VUR. VUR is the most common cause of recurrent UTI, and all recurrent UTIs should get ultrasound, DMSA, MCU. Remember, all recurrent UTIs should get ultrasound, DMSA scan to look for scarring, and MCU to look for VUR. Now many students told me that there was another question which came in this INICET exam on what should be the order of investigations in a child less than 3 years with UTI. So students, in addition to your classes, we do every Wednesday, we do a grand round, we do a lot of interactive sessions on YouTube. Now one of the interactive sessions which I did with you on YouTube was on UTI. And I'll just show you a glimpse of that session on the EQ session on UTI. So I would suggest all of you to please at least see the EQ sessions on UTI and other sessions by me on YouTube. Here's a glimpse. Now, I'm currently the secretary of Indian Society of Pediatric Nephrology. So in our country, we have a Society of Pediatric Nephrologists. And what we thought of in 2011, we gave guidelines. So every child who comes to you with UTI, if he is less than 1 year, he should get all of these 3 tests. This is a very important MCQ, everyone. Every infant with UTI get all 3: ultrasound, MCU, DMSA. Now between 1 to 5 years, we get ultrasound and a DMSA to look for scar. We get DMSA after 8 weeks. If any of these is abnormal, we do MCU. Okay. Now after 5 years, we just do an ultrasound. If it is abnormal, then we do other tests. Okay. So this was an evaluation in the first episode of UTI in any child, and I was the secretary of our Society of Pediatric Nephrology till 2 years back, and we've been discussing this. So of course, ultrasound should be done in all children with UTI. In a child between 1 to 5 years, you do DMSA. And if any of these is abnormal, ultrasound or DMSA is abnormal, we go for MCU. Remember, recurrent UTI, all these 3 tests should be done. Remember that. Now again, we've been telling you in the last 2 years in your all the DVTs, all sessions, that hand washing is important. You should know the steps of hand washing. You should know when to use alcohol based sanitizers, when not to do. So what I'll do is I'll just show you a video from the WHO. What WHO talks about alcohol based formulations, how to do hand rub. And I'll just show you 10 seconds of this 1 minute video, just a glimpse.
Appropriate when hands are visibly dirty or after using the toilet. In these cases, hand washing is required. Hand rubbing should take you 20 to 30 seconds. Use a timer or count 1, 2, 3, 4, 5 in each of the following steps. Apply a palmful of alcohol-based hand rub in a...
So, of course, this was a common sense question that if hands are visibly soiled, of course, you should go for hand washing and not an alcohol-based hand sanitizer. So please do look at COVID-19, do look at hand washing with you when you're going for your NEETPG and the next INICET exam. Now again, a repeat question. This question, you should not have even spent 10 seconds on this. This was a typical Gottron's papule. Now, in your last INICET, let's look at INICET May. I told you in your last May INICET also that there was a question on a boy with joint pains and a typical Gottron's papule. Remember, juvenile dermatomyositis is the most common inflammatory myositis in children. Most common inflammatory myositis in children, in which they have proximal muscle weakness and a characteristic heliotrope rash. So remember, they have a classic heliotrope rash on the eyelids, Gottron's papules, plus any 3 of the following. They may have proximal muscle weakness, muscle enzyme elevation, EMG changes, and muscle biopsy. So you need to have 3 of the following: weakness. So suppose they ask you, looking at this child, what is your next step? My next step will be to get a CPK enzyme, a muscle enzyme elevation. Of course, the muscle biopsies will show necrosis and inflammation. So there was no doubt about this. It was a repeat question. It was Gottron's papule. Of course, the rash is on the eyelids, not on the hand. So that was all and about your INICET questions. And students, I'll be doing a lot of high yield videos for you on YouTube and the DAMS exclusive club. So do tag me or ask me questions if you want to ask me any questions. I'm Sidharth Sethi. I'm a pediatric nephrologist, and on Facebook I'm on Pedia for PG. Here are my social media handles. You can email me if you have any doubts on sidsdoc@gmail.com. And I'll see you again in DVT and other very important sessions on YouTube and the DAMS Club. Thank you.